So this video is more about the assistant role for an RSI, so rapid sequence induction or rapid sequence intubation. So you would have your doctor ready to intubate a patient. We are going to use RSUS for our checklists. So checklist, intubation, we're going to say non-COVID patient, and this would be talked through with the whole team. And as a nurse, it's not your responsibility to have all these answers, but you might be asked to read out the checklist. So you know, the checklist is on RSUS. So the first section is all about preparing the patient, which will include pre-oxygenation of a patient. So before intubating, we need to optimise the amount of oxygen a patient has. So to do that, an anaesthetist or an intubating ED doctor even would want this piece of kit, which is known as either a water circuit or a Mapleson C. As you open it out, I don't know if you can see that there, this is how it comes. And the important thing is, do not ever throw this away, because this is the gadget we use, the white piece, to connect the tubing to the oxygen. So this would then fit onto the oxygen here, she says. Okay. This then attaches, I believe with this bit here, is that right, Doctor? To the mask, and the doctor can then pre-oxygenate. And if I turn this on, you will see that the reservoir bag will then fill up with oxygen, and the doctor can pre-oxygenate the patient. They can also ventilate the patient using this as their bag. As a nurse, we would never ever use this to ventilate a patient. We are trained to use a bag valve mask, which is hanging off the edge of the airway trolley here. Okay. So whilst I'm going to turn the oxygen off for training purposes, but I wouldn't do that obviously if this was real. And whilst the doctor is pre-oxygenating the patient, we can continue to go through the checklist. I'm not going to read this out, I want you to familiarise yourselves with this checklist. Prepare the patient, one list. Prepare the equipment is the next list. Preparing the team is the next list, and again you would be reading this out, but you'd have a team leader who would be answering these questions. And then preparing for difficulty. So in the room, I will have my kit dump, which is here, always set out in RSUS, under the desk, with critical care written on a sticker at the front. And this is everything that would be needed for an RSI, including the water circuit, which we've already opened. We also need to plan for if there are problems. So there is a phrase that is can't intubate, can't oxygenate, and that is a medical emergency. So we need to know, what are we going to do if that happens? So plan A is intubation, this is what we're preparing for. Plan B is if we're struggling to intubate, we go back to basics. So back to just using a bag valve mask or the water circuit and simple adjuncts. If that doesn't work, plan B is an LMA. I take that back. Plan B is we can't intubate, so let's try with an eye gel or a supraglottic airway, which we have on the top of the trolley. So that's plan B. Plan C is go back to basics. So actually get rid of all the fancy kit, go back to bag valve mask or water circuit, simple adjuncts. Can we ventilate the patient? If we still can't ventilate the patient at this point, it will be declared an emergency. Can't intubate, can't oxygenate the patient, so at that point the doctor would want to go for front of neck. This is a very, very, very rare occurrence, but on the bottom of the trolley here you will see front of neck kit. This is very basic. In the big grey cupboard in RSUS, we've got a much bigger kit for front of neck access that's got even more fancy stuff in, so that may well be asked for in that specific emergency. So we've gone through our checklist. We're happy that everyone knows who's doing what, that we've got all the kit that we need, and that we have a patient that is going to be sedated and anaesthetised so that we can intubate them. And prepare ahead. So something else we are going to need ongoing is to keep this patient sedated, an infusion of probably propofol, but whatever is prescribed. So this patient is given a stat dose of a bolus of whatever drug the doctor asks for, that they will give to anaesthetise the patient, and then we'll need to give an infusion of whatever afterwards. Okay, so I have my glamorous assistant here who is pre-oxygenating the patient. I have my kit dump here, of which for training purposes I have got some of the stuff out ready. And what this doctor is going to need to intubate the patient is a laryngoscope, and we may well use the CMAC. So this is a video laryngoscope, so the anaesthetist or the doctor intubating can see on video, but it means everyone else in the room can see what they can see. So these are the blades, the laryngoscope blades that are used to go with the CMAC that attach electronically here. But again, for video purposes, we're going to use an old-fashioned laryngoscope. A laryngoscope will always be held in the doctor's left hand. The next thing is the doctor may well want a bougie, and a bougie looks like this. It's an essential piece of kit that is used like an introducer. So if a doctor has requested that I am their assistant, I will have this ready, and I know that we hand it to the doctor. Trying to find how to open it. Comes out this end, here we go. So there is a very slight bent end and a straight end. So the bent end is the end that goes down the patient's trachea, not the straight end. So I know when I hand this to the doctor, I'm going to hand it to them bent end first. So when the induction drugs have been given by whichever doctor has been assigned that role, and we have waited the designated amount of time and the doctor is happy, the doctor who is intubating is happy, then they will indicate to me what they want next. So, what would you like next?
So, thanks Penny. I think the drugs have had long enough time to act, so I'm going to put that down, and I'm going to first of all have a look. And if I'm using the CMAC, I'll be looking down the throat, and everybody else can be looking at what I see on the screen. So I'm not getting a particularly good view just here, which means it's even more important that I ask for a bougie. So could I please have a bougie first?
Bougie.
Thank you. And I'm not getting a very good view just now, so would somebody apply a little bit of pressure to the neck for me so I can maybe get a better view of the vocal cords?
So I find the cricoid cartilage and I press. Is that enough?
I think so. So I believe that the bougie's in, and if we were using the video screen we would have seen the bougie go down through the vocal cords. So the bougie's in. So now what I'd like you to do, you can release that pressure for now, and if you can now thread the tube onto the bougie for me, Penny.
Okay.
You need a bit of lubrication to get it on. So a really important step just now, Penny, is that I want you to hold securely onto the bougie, because I'm going to let go of the bougie now, and I'm going to take the tube. So have you got the bougie?
I've got the bougie.
And I've got the tube, so that then means that I know the bougie isn't going down further while I've tried to railroad the tube over the bougie through the vocal cords, and I've seen that happen now. So could you remove the bougie for me, please, Penny?
I'm removing the bougie now.
I'm holding the tube securely at the position where I've seen it go through the cords. So now what I'd like to do is attach our oxygen supply, so remove the face mask. We need a filter in this circuit as well as end-tidal CO2, please.
So filter, end-tidal.
And then if we can attach this now. And I'm holding onto the tube all the time, and now I'm going to start to see if I can inflate the lungs. So if we had oxygen on just now, I should be able to squeeze this bag and see inflation of the lungs. And can we please inflate the tube's cuff, Penny, with 10 mils of air in a syringe?
So 10 mils of air attached to the end of my cuff here. And do you want the full 10 mils in?
Yes, until we've got some tautness in that little blue sand.
Keep going?
Yep.
Happy?
Yep.
That's 10 mils in.
Just reattach that for me. And then the final thing I want to do, I want to make sure that I'm happy that the tube's in the right place. So I'll be having a look on the monitor for end tidal CO2 trace. I'll be making sure by listening into both axillae that I've got air going into both sides, and possibly over the stomach as well, to make sure there's no esophageal air. And then I want to tie the tube, and that might be something else for some help with Penny. So
Absolutely.
there should be tube ties available,
So
please.
on our kit dump we have tube tied here, and so this we would cut, it would go round the patient's neck here, through here, and then we tie round the tube this way here.
And I'm just making sure that the tube doesn't slip in or out whilst we're sorting that securing of the tube with the tube tie. Thanks, Penny.
Lovely. One thing you may be asked for is something called a catheter mount, and this is just an extension piece. As you can see, the weight of this is pulling directly on the tube here, at risk of pulling the tube out. So we may be asked to pass one of these, which attaches to the end of the tube here. This attaches to here, and it just gives the doctor a little bit more play without pulling on the tube. That's it.